discussing this topic, real subject experts. On my left, Temmink, who's stepping in for Laura from the NHS, Chris Hopson, Chief Strategy Officer of NHS England, Kirsten, Director of Public Health for Camden, and of course Steve at the end, last but not least, MP for Exeter and Chair of the Pharmacy APPG. My name is Patrick King, I'm Senior Researcher at Reform and the author of a report last year on the power of prevention and boosting vaccine uptake, which is the reason that we're all here today. Really looking forward to people's remarks. I think from December 2023, there's some really great progress in the NHS's vaccine strategy around improving access to vaccination and the convenience and ease with which patients can book their vaccines in. And our focus in the report was on the kind of demand side of the equation. What is it that makes people want to come forward to be vaccinated? What is it that gives them confidence? And how do we address those regional disparities in uptake for vaccination? And so you don't want to hear from me, you want to hear from the panel. And so I'll pass on to Caroline for her opening remarks to begin with.
I think I'm passing to me.
So, hello, my name is Chris Hopson. As you've heard, I'm the Chief Strategy Officer. Would it help if I stood up or not? Can you hear me at the back clearly?
Yeah.
Charlie, what do you think?
You sound beautiful, Chris.
Oh, Charlie, thank you so much. Thank you very much. So look, great to see you all here. If I'm honest, I'm not entirely surprised there is such a big audience, and I think there's really kind of two reasons for that from where I sit. The first is, well done Reform for yet again producing an excellent kind of paper that I think is a really great stimulus to the debate, and recognising that will have been a helpful joint venture between colleagues at Reform but also people actually supporting it. But also secondly, my kind of sense, and again I'm sure we'll get into this, is that actually vaccination's definitely kind of coming higher up the strategic agenda of the NHS and indeed you might argue wider healthcare delivery. So really pleased to be here to kind of have a proper conversation. There's two of us because I'm the generalist and this is the expert, and please bear that in mind if we get to questions. But look, what I thought I'd do is just give you a bit of a kind of sense about where we're up to. We really did welcome the Reform paper. We thought it was a really helpful and important contribution to the debate. It's also, I thought, a welcome reminder of the areas where we need to kind of keep up to the pace. And again, I think I was just having a really good conversation briefly with Kirsten, who, by the way, is from my local borough. I'm one of her residents. We were just kind of basically just saying it was just really interesting about the degree to which the COVID-19 pandemic really kind of put vaccinations absolutely front and centre stage, where I think many of us would argue they probably should have been more in the first place. And I think a real strong view that we felt we learned a huge amount from that. I think what we would say, happy to be challenged, is that we've historically, as England, performed well across routine immunisation, seasonal and outbreak vaccinations. We know we've had to deal with some really kind of quite difficult issues like vaccine hesitancy and vaccine scepticism. Interesting, not just an issue for us, but actually being felt kind of worldwide. And I think we've been, as I said, really focusing on how we maximise uptake. I think it's a really interesting kind of challenge, isn't it? A kind of classic delivery challenge about how an organisation like ours, or a system like ours, gets the right balance between what we do at a national level but then also what it's appropriate to kind of devolve locally. I think for me, what particularly the COVID-19 pandemic absolutely kind of showed was a recognition that we really did need to focus more effectively on underserved communities. And I think, one can, dwell on the anecdotal, like I particularly loved the Bristol story of the barge boat that was going around administering effectively vaccinations to the people who lived on narrowboat community. But I think a real kind of sense that if you are to get effective vaccination, really thinking through the delivery model. And it's great that Kirsten is sitting here because I think we recognise it's absolutely a joint venture between ourselves and local government. Patrick, thank you for mentioning our vaccination strategy. We published that in December 2023. That really set out about how we needed to better use technology, targeted outreach, and how improved access, all of that together, can start to address the declining and variable uptake. I mean, again, I was in a discussion at our executive table about 3 or 4 weeks ago where we were looking at children and young people as a theme, and just that real sense of we know we have a very significant challenge in terms of vaccination rates for children and young people, which again we were talking about a bit earlier. And just, I think, a very clear recognition, which I think hopefully all of us in the room would recognise, that vaccination is arguably the most effective public health intervention we've had since kind of clean water. I mean, really vital. The strategy, as you know, probably for those of you who've read it, that effectively 3 kind of key pillars. One is improving access, including expanding online services. And again, I think we're actually incredibly excited about the opportunities that the app and the amount of take-up we've now got on the app potentially offer in this space. Second pillar, I think, is delivery in convenient local places with targeted outreach to support uptake in underserved populations. And then thirdly, I think, really importantly, a more joined up prevention and vaccination offer. So holistic services offering multiple vaccinations for the whole family. So for example, flu alongside MMR and HPV kind of catch up. We know that there are some areas that we need to improve. For example, MMR I think would be a very good example of where we absolutely kind of know that we need to get better. But again, sorry, I keep saying we packed a lot into our 5-minute conversation, but just again, really interesting, Kirsten talking about the work that she'd been doing to kind of, in her borough, to really kind of drive up take-up. I think we also know, I know there are a number of you from community pharmacy in the room. I wanted to particularly make the point that I think we kind of recognise that making the appropriate use of the full range of providers is really, really important. And I just want to make the point that we absolutely recognise that the community pharmacy sector, alongside general practice, alongside other providers, is absolutely fundamental in terms of ensuring that we deliver the vaccination strategy. The other bit from my point of view as an executive member at NHS England is just getting that balance right in our new statutory structure, about what is it, 2 years old, 2.5 years old now, of effectively what is it that we should be doing nationally at a national level, but also, as I was saying earlier, what should we devolve to ICBs, and inevitably, given that we're still relatively early on in the life of ICBs, just making sure that we get that absolutely right. But I think it's a really good topic to focus on, as the paper proved. Very much looking forward to the discussion.
Thank you for that, Chris. And I think, came through really strongly how important those local delivery approaches are. And it was a big finding of our report, actually, that community pharmacy has a key role to play here. So it's great to see so many people from community pharmacy in the room, but also local authorities and public health. And it'll be great to get Kirsten's perspective on that. The other big thank you I should give before I move on to Steve is Novavax, who have supported this project. Reform's a small charity. There are actually only 10 of us, despite our output. And the way that we're able to produce reports and put on great events like this is through partnership. So thank you very much to Novavax. And I'll pass on to Caroline.
Caroline. Thank you. Sorry, we swapped things around to keep you on your toes.
No, of course.
Good evening, everyone. Thanks for having me. As Patrick said, I'm a fairly last-minute shoe for Laura Norris, who is due to be here, but hopefully we'll cover what you're interested in. So I am the Director of Vaccination for NHS England. So my role is around overseeing that delivery of all of our routine and seasonal vaccination programmes. So as Chris has said, we're just over a year into the delivery of the vaccination strategy. So what I thought would be useful to do is actually touch on some of the work we've done already. We are working towards delegation of vaccination services to integrated care boards in April 2026. So they will take on the responsibility for commissioning. But there's a huge amount of work going to get ready for that point in time, but also to continue to progress the strategy in the meantime. So ICBs really are leading the way in terms of the innovation around vaccination and driving uptake of our vaccination programmes, and working on the basis that actually those who are closest to the population and know the community are the best people to design what that service looks like and work out what that model looks like on the ground for their own people living in their communities. So we have, as well as lots of work going on across the country, we have 12 dedicated demonstrator systems who are testing out different models for us. So part of the strategy implementation was that we shouldn't wait until we have absolute perfect evidence on everything that works to go ahead and move things, but actually to try things out and see what's right, evaluate it as we go through and test that, and where it works, implement it and spread that learning. So we have Lancashire and South Cumbria ICS, who have been working with their local providers to allow care home staff to vaccinate for COVID and flu, to vaccinate their own residents and staff, which has been really successful about encouraging uptake, but also making it easier for them on the ground to deliver and for their residents to receive those vaccinations. We've also got examples in Birmingham and Solihull of where they have commissioned the local community health services to vaccinate infants. So in addition to that important core offer in general practice, to look at what the alternative models and easier ways of getting access for their population. So they've commissioned their local community trust to help add that extra level of convenience. And then in North East and North Cumbria ICS, we have a real collaboration with GPs and local partners looking at how they can use the money that they've got available to really target that into their most challenged areas, to work with their communities to build that confidence and the confidence for people to come forward for vaccination. So we've also moved on things a huge amount around vaccination digital services. That's another really core thing for us in terms of delivering the strategy. So we're working towards making sure that people know what they're eligible for and they can see whether they've had it through the NHS app. We now have all of our maternal vaccinations in trusts being delivered through one single system, so that data is now flowing to us and we can see who's been vaccinated and areas where we need to target that. So a huge amount of work going on about recording, consenting, and being able to see what vaccinations that people have had, including in a school setting, making that easier for parents to have that entire journey across a vaccination being offered in school. Also, Chris has touched on childhood vaccinations in MMR. We've had the biggest national childhood immunisation campaign over the last year, working with DHSC and the UK Health Security Agency, with a combination of paid for and no cost activity, trying to really encourage people to come forward on top of the targeted invitations that we've done nationally as well. And we have our annual back to school campaign as well, really encouraging people and putting out the message about why vaccination is important. And then just finally, just wanted to touch on data. So for us, data is a really essential part of making this work, being able to see what populations aren't being vaccinated, aren't coming forward for various reasons. So we're doing lots of work about making that more available, and meaning that we can react to that much more quickly and operationally, so that we can target and adjust our methods so that to make sure that works for populations. So I'll leave it there, Patrick.
Thank you so much. And I think, again, really clear that kind of balance between national and local is so important. What are the things that can be done and are useful to be done at a national level? Things like the NHS app, things like the right data infrastructure, or the enabling factors at a local level that allow delivery to be as strong as it can be, including in schools and including for childhood vaccinations where there's kind of a particular need to focus. I think now I will come on.
We should start chairing you all the time. Fantastic, thank you. I'm Steve Race, I'm MP for Exeter. I'm the chair of the All-Party Parliamentary Group on Pharmacy, so I work very closely with the pharmacy sector to advocate for community pharmacy within Parliament, and that's across party as well. So our membership is from most political parties in represented in the House of Commons. So I also have a bit of a background in pharmacy, but from not as a pharmacist, but I worked for McKesson so when poor old Lloyd's Pharmacy still existed, and I sat on the board and led an exceptionally talented team of people who engaged with government on negotiations, and my job was to try and create the environment where community pharmacy felt a bit more valued than it has been in the past. And I think we touched on the sort of COVID pandemic, and I think not only did that throw the use of vaccinations into a better light, I think that the role of community pharmacy actually was incredibly important during the COVID pandemic, partly because they kept their doors open throughout the entire time, one of the few bits of primary care that did, and so accessibility to healthcare throughout that entire period of time for patients and residents in Exeter and elsewhere was incredibly important. Pharmacies obviously already play a huge role in vaccinations. So over the last few months, they've delivered 3 million flu vaccinations. They've done 9.9 million COVID-19 vaccinations in 23-24. They obviously also do travel vaccinations as well. And I think that people do like having their vaccinations at a pharmacy because it's accessible. They're often present in under-doctored areas, in lower socioeconomic areas, and people trust their pharmacists as well. They trust their pharmacy teams to deliver their vaccinations and their medicines for them. The pharmacy has very, very high patient satisfaction, for example. And if we are going to get into those sorts of communities that tend to have much more vaccine hesitancy, then community pharmacy is one of the main routes that we can do to use that. What next? I think we do need to build on this sort of success of pharmacy in the vaccinations process. We need to offer more vaccination services, and I think there is a question around sort of national contracted services versus sort of local commissioning. I think the pharmacies often enjoy the sort of the certainty of national contracts, and scrabbling around for local contracts I think it can be quite difficult for pharmacies, but and what we want to avoid obviously is a patchwork, and I think my experience of my ICB in Devon is that the ICS that it oversees is that we have a postcode lottery within our ICS, never mind across the country, which we really do want to avoid. There are obviously vaccinations for other conditions that could come under a national contract, and in the future as vaccinations for new conditions come to the fore, we should be considering community pharmacy as part of that. The benefits are better health outcomes and better health equity within our communities. It's absolutely vital that pharmacies play their role and can play the role in moving the NHS from hospital-based care to community-based care, and from treatment to prevention. Obviously, two of the major steps that the Secretary of State wants to take with the NHS, and then obviously there's the relief of pressure on GPs as well. So similar to Pharmacy First, which has been rolled out, we need a bit more sort of public knowledge of how to work Pharmacy First better, and also within the system I think there needs to be better understanding of what Pharmacy First can offer. But for example, about 400,000 GP appointments have been saved already per year with pharmacy vaccinations, and I think that is based on some assumptions. So community pharmacy is struggling. It's been on flat funding for many years, and that was after a significant cut. We need investment, and we also I think need within the NHS England system, we need agreement on the role of pharmacy, and that agreement across primary care about what pharmacy is there for. I think some of the tensions are embedded in the system. So, for example, GPs and pharmacy essentially having new money for flu vaccinations, and then the annual sort of fight over who does the most flu vaccinations. Is it GPs or is it pharmacies? And sort of that's embedded within the system. So we do need to have an agreement within the system and then embed that about what the role of pharmacy should be and what the role of GPs should be. And it has to obviously be about every part of the primary care sector working at the top of their licenses, being the most productive that they possibly can be. So I'll leave it at that. I'm looking forward to the conversation. Thank you for the invitation. Thank you.
Thank you very much, Steve. I'm glad you pointed to those two system shifts of sickness prevention and from hospital to community, because I think vaccination is a kind of case in point of why those two things are really closely linked. And unless we do the hospital to community shift, then we won't also see the sickness to prevention shift, which is kind of a great point to bring in, I think, Kirsten, to give that local perspective.
Quickly from me, because I'm really looking forward to the discussion. So I really see that local government is key in supporting high uptake and equitable uptake of vaccinations, and I think they're slightly different. We know they're slightly different, but they require different approaches. Local government has a unique role into communities. We work very closely with them. Our elected members are very deep into their communities. They often bring issues to us. So we see ourselves working in partnership, and that's a legacy from COVID, where we really solidified those partnerships together. I'm also the London lead for the Association of Directors of Public Health for Immunisations, and I see the close relationships that we have across UK HSA, NHS England, and local government. And I think that we work in partnership, and particularly with the measles outbreak, we really worked in partnership in a way that we never have before, I think, in terms of the work that we're doing together. I see a robust national schedule. For most people, the sort of national schedule of delivery works well. But there are increasing cohorts for whom it doesn't work, but we need to have different approaches. We have a big schedule of robust call-recall, but we need the hyper-local. We talk about the push and pull factors. We're pulling people into servicing, but we need push as well. In Camden, we've had very low uptake. Traditionally, we have really focused on MMR uptake. In 24 months, we've seen a 7% increase in MMR1, a 6% increase in MMR2, and interestingly, MMR2 was slightly more difficult to be able to get that increase. It tends to be delayed. We don't quite know the reasons for that, and a 6% overall increase in primary immunisations, because we saw for the first time that dip into primary immunisations. And the way we've done it is we've done everything. When we talk about the amount of resources we've had from the public health grant into it, has been significant, and in partnership with our ICB colleagues and our acute trust colleagues. So we've been working in partnership with University College London hospitals as well. So we have seen it as a whole system push. We were one of the first boroughs which looked at mobile delivery of MMR. And that had a significant lead-in time, because at the time, and we really welcomed some of the changes to data, we didn't have the data infrastructure to be able to do non-primary care-based MMR. The way we worked around it is we had to write out, it was old-fashioned, and then we had to fax it over or scan it, or what the modern way is, probably some kind of computer way, and then we had to manually input it into the patient record, because we wanted to do a proof of concept, but mobile delivery had never been done before. What we saw from that was actually mobile delivery with the clinician input didn't work. So people want a message from a trusted healthcare professional to tell them to go and get a vaccine. That's really important. The times we didn't have the push and text message from the GP to the bus, the mobile bus, it didn't work. We got very low uptake. So the trusted healthcare professional is really important. And it's not just about the mobile delivery. So we've had our mobile bus on one of our estates. We've had it through family and children's centres. But the appointment time is triple what we would have in primary care. So the time resource is quite significant. And actually lead-in conversations are really important. People will want maybe 2 or 3 conversations before they go and have that vaccination done. So the time it takes is significant. And we've also seen the population, hidden populations in London are hidden for reasons, very complex reasons. So we had whole families come where we have lots of our community languages that we know, and every borough will have produce documents and translate. But for the communities that that's not sort of our community translated languages, they're finding it very difficult to navigate a system. We had one family that came who had 5 children, none of them immunised, but were willing to be immunised, but couldn't navigate a system and were finding it difficult to. We've also had community champion programs, so getting residents involved and having that community champion approach is really important. And again, the role of trusted health professionals. And we've also trained all of our health visiting staff and maternity staff called as a Jitsu Vax training. So it's a research program which is looking at structured conversations for health professionals for people who are more vaccine hesitant. Because often healthcare professionals, A, don't have the time, or maybe sort of reluctant to sort of engage in maybe what would be quite difficult conversations. So there's something around confidence and coherence of messaging. And then I think finally, I think the opportunity is huge, but I think the time must be now. I think there's an urgency to what we're doing.
Fascinating. That's really interesting and useful. And I think what came through really clearly is the message is important, but the medium is also really important. And unless people hear the message in the right medium, then we can't boost vaccine uptake. At this point, I'd usually ask some questions to the panel, but I'm aware that we have a very full room, so I might throw it immediately open to the audience. I'm sure lots of people will have questions for the panellists. Yeah, we've got one at the back there, and one at the front here from Charles.
Hi, I'm Alex from GSK. So thanks for the presentation, it's really interesting. And I think there seems to be general consensus around vaccinations in local places. I think that comes across clearly to help try and address health inequalities. So with that in mind, just wondering what the kind of specific timelines and milestones are to achieve that. So the local vaccination strategy was published over a year ago. So I think these things often take time, don't they? So what's the kind of like timelines and milestones you're working towards to achieve that?
Yeah, thank you. And Charles?
Yeah, I think mine is for Chris, looking at the strategy and the three sort of focal point, with what Kirsten has talked about, the pockets that are underserved, hidden, within the strategy. I didn't hear any mention of the voluntary community faith and social enterprise sector. But we know during the vaccination rollout during the pandemic, there was actually those pop-up clinics that worked. So where is all that learning? Where is the investment to follow that, knowing that that model worked?
Chris, could I come to you for the BCSE question, and then Caroline might come to you for the question on timelines?
You might want to follow on behind me on the
That's
BCSE
fine.
question. So you're absolutely right, Charles, absolutely kind of fundamental, and you're right to point to the COVID experience where, there's absolutely no doubt that trusted local community voices were absolutely key. And interestingly, religious voices, I thought, very interesting in quite a lot of, kind of communities. It was the religious voice that was really important. So that is absolutely kind of baked into the local strategy. Clearly, what you wouldn't want to do is say, from a national level, you must do this, that. It's local organisations, particularly working with local government, that I think enables us to develop that strategy. You then do go on, as I would expect you to do, to talk about the importance of the funding. And I think we absolutely got to recognise that one of our longer term missions here is to provide a greater certainty of funding over a longer guaranteed period. And ensuring that we are able to do that within the kind of inevitable fiscal constraints that come being as a kind of public service is really key. I would be the first to say that we still have some distance to go, but equally I think what I might point you to is there are certainly, a great privilege of my job is to kind of go and do lots of visits and have lots of conversations. I think I can point to you to various ICBs where actually, and places where, places probably more in some sense important than ICBs, where that is actually beginning to happen. But I absolutely recognise from all of my conversations with VCSE partners that if you want us to kind of play the role that we need to play, you not only need to build the partnership, but actually you need to give us greater certainty of multi-year funding. And I'm pleased to see Kirsten's nodding.
Yeah. Thanks, Chris. And I think just to add to that point as well, I think in terms of how we're sharing it, there's a huge amount of work already going on to share that important work that's happening in different communities and ensure the sort of cross-fertilisation about something that works well in one area. It may or may not work well, but how do we share that? We're also doing some work with academic partners as well around evaluation of all that work that happened during COVID to make sure, as we hopefully secure that funding, that actually how do we make sure we get good value for money and continue to pursue the interventions that get the best return and the best impact in terms of building that confidence and leading to a vaccination. So we're working on that at the moment to make sure that we really use that most effectively and can continue to support those interventions that work and have worked during COVID. Shall I move on to
can I ask you the timeline question as well?
The timeline question. So in terms of timeline, so we're already rolling out in different providers on top of the core offer. So obviously we have our core offer for for preschool immunisations in general practice, for school age immunisations through the school service, and then our routine programmes through a combination of general practice and pharmacy for seasonal already. We have through this year we've implemented this year, I've forgotten we're in January. In September we launched 2 new RSV vaccination programmes, and as part of that we had a number of early adopter sites at the Institute of England Community Pharmacy, so we're already doing that to start to build on that expansion of the network. So really for us it's all the enablers that need to be in place to do that. So we have managed to, we've got data flow and we've got the data systems able to record. It's also the link to the National Booking Service, so that if there are different models, people have a single place to go, know they can book their vaccination through that route. Because I think that's the other thing that's really important for us, is that people know how to access that vaccination. So we will be expanding that through the RSV programme, but also looking at what other things over the next 12 months that we can do. So that work is underway. So really we're looking at that kind of 12 to 18 months timeline to hopefully be able to support all that local design.
Thank you, that's useful. Can I come to another round of questions? Kate at the front, and then if I could also come to you at the front.
Thank you. I'm Kate Ardern. I used to be the Director of Public Health for Wigan, which under my leadership we had 95% uptake in every single vaccine, including MMR. So just point that out. I was also and I actually had one of the country's leading anti-vax campaigners living in the borough, which is I'll come back to in a minute. I currently work with Patrick. I was actually one of the principal advisors on the reform report on Immunisation, and previously I've also been a health protection consultant, and I was Greater Manchester's health protection and emergency planning lead during COVID, so I was Andy Burnham's principal advisor. So, see, and I've just had my flu vac at a pharmacy.
Very good.
I can strongly recommend our local pharmacy. I'm very pleased to hear both Chris and Caroline sort of accept the reform report recommendations and the progress that you're making on that, and that's really welcome. I think we were particularly focused on the need to be as flexible as possible and really open up access. So if I could urge you to speed up that process, that would be really important. But very importantly, our first recommendation was about co-locating Immunisation teams from the NHS back with DPHs. DPHs like Kirsten really know their patch. They have the local intelligence, they know the local assets, they know the local challenges. And I think perhaps if you really want to tackle vaccine disinformation and improve vaccine confidence, I don't like the term hesitancy, it's much more about improving vaccine competence.
Yeah.
Then you need to shift assets into the kind of conversations that Kirsten's talking about. So what I would like, perhaps Chris, there's one budget you do control, I think, in NHSE, and that's how the inequalities money's spent, because I think that's in your remit. Then perhaps ICS is feeding back through the Confed saying they don't know how to spend their inequalities money. Isn't Immunisation the primary focus for that? So whatever else they don't spend it on, could they really focus their inequalities money into funding the kind of conversations that Charles is talking about, and also prioritising, I think, our very poor performance at the moment on childhood Immunisation. I look at some of the stats, and I look at things like MC, the MenC and MenB vaccines, which are down in the 80s. I'm long enough in the tooth to remember what it was like before we had those vaccines. I had 2 kids, 14-year-olds, die, classmates in Liverpool back in the 90s. I couldn't do anything to prevent that then because we didn't have the vaccines. We're at risk of that happening again now. So I think there's a bit of urgency about recovery of performance, and that perhaps, Steve, is where your APPG could come in to look at recovery performance, the role of pharmacy, but also I think to help Caroline and Chris a little bit, I think perhaps something we need to come back to, Patrick, is the role of JCVI as well, because I think there are some issues about national policy. So perhaps, Chris, you could respond about policy's investment in that.
I might give Chris a little hand and just try and condense that down a little bit. So two questions on childhood vaccination, on inequalities, and I might also bring in Stephen Kirsten on the inequalities and childhood vaccination question as well.
So, Kate, as one would expect, you've made your case very effectively. On the co-location point, and Caroline, you should really come in on this. I think the argument that you're making about the importance of the quality of the relationship between the NHS and local government is absolutely key at both the strategic and the delivery level. One of the things that's really interesting is another area where we're absolutely kind of finding this is that, for example, in discharge, where effectively physical co-location has made a big difference. So I kind of get the argument, and I think it's important we should go as far as we can. I would just make the observation there are some certain interesting issues in terms of when you haven't got completely coterminous boundaries, for example, there are some interesting kind of challenges. In terms of health inequalities, couldn't agree with you more. It is a really kind of important issue in terms of it's a very, very obvious area where if you look at the delivery of healthcare services, immunisation and vaccination is something where we need to do better in terms of tackling health inequalities. And I just do want to, again, echo your point about I do think we all need to keep a really close eye on childhood vaccination levels. It's great to be, in a sense, surrounded by, on the one side, you've heard the real effort that we've put in this year on catch-up. It was delightful to hear what you've done in my home borough, but as you said, it was really, really hard won. It took resource and focus, and you can't just do it once. You absolutely need to kind of keep doing it. So couldn't agree.
Yeah. Just to add, I mean, I think we can all see, and probably in the last few years of that catch-up work shows that catch-up work is much harder than actually just getting it right at the beginning. So actually, that's where our focus needs to be: is making sure that people are coming forward to be being vaccinated as per the schedule. I think just to add, I think delegation gives us that opportunity for that closer working as well locally. So I think that's how we see we can enact that, is through that responsibility of commissioning at a local level and through those integrated care partnerships, working locally with people working together.
Great if you could if you could actually co-commission with the DPHs.
Kirsten, can I come to you really quickly on childhood vaccination as well and Camden's experience of that?
I just wanted to make a comment about the inequalities, because I think as more vaccines come on stream, we're going to see widening health inequalities unless we're building the trust now. So it's something really important about the future health of generations, and actually, you know, the strides in RNA vaccines aren't going to be realised at a population level unless we're seeing this this increase in confidence. And I think some of the increase in confidence is also to do with trust. So there's a big thing around people's whole experiences of healthcare and civic society impacts their trust, and we're seeing this now, falling trust, looking at falling declines of vaccination. So it's not just, I think, local government, NHS, it's sort of a whole picture effort. And the work in Camden, you know, it's been, you know, a considerable amount of public health grant spent. I mean, it is cost effective. I think we're quite confident about that, but particularly where you've got service pressures, you know, particularly demand-led services like reproductive health services, substance misuse, it can be very difficult for DPHs to carve resources out for the continuous, and I mean, it's every week continuous work that we do. So I think there's something around also making sure that the public health grants, you know, ring fence around immunisations is really reinforced, because we need that resource to be able to do the hyper-local work to support our NHS colleagues.
Yeah.
And sorry, one other thing, we're not enough making the strategic links between the work that we're doing around childhood vaccinations and winter pressures and acute work. So we know that high uptake of seasonal influenza in school-aged children is effective at reducing admissions in over 65. But I've never seen a winter pressures plan where one of the targets is to have high uptake of primary school in, but we're seeing them in separate conversations.
I think it's a really well-made point about the kind of wider trust question of not just trust in individual vaccines, but actually trust in government institutions and in public health.
Yeah.
We had a question from the lady at the front, which is where we didn't get to,
Steve
but then Steve, can you
No, I think you're right around trust, and I think it keys in very specifically to children as well, and especially the, frankly, quite frightening number of children that are outside of the mainstream school system, are either being homeschooled, fallen out of the system altogether, because partly for some families it's lack of trust in the support that their child will get in schools when your child has special educational needs, for example. And I worry that they fall out of all systems because they've fallen out of the school system, they've lost trust in all systems, and then you therefore miss lots of opportunities to be vaccinated in schools. That also goes over into slightly less, slightly more formal, but sort of religious schools, for example, making sure that those children get the right sort of healthcare vaccinations as well. And then just on accessibility, obviously, just to make the point about pharmacies again, and that the vast majority of people live within a 20-minute walk of pharmacy, and people like pharmacies because you just walk through the door. You don't necessarily need to make an appointment. You can we get a lot of older people in particular not wanting to bother their GP because it's not important. They don't necessarily think their health is important, but they do want to see someone about it, and they will go to see their GP. So there is and that's partly where the trust sort of stems from in the community pharmacy system. I think knowing your community pharmacy and being able to go there for advice as well.
I think it's a really good point, and if you're someone that's unlikely to present in a school setting for a vaccine, or you're unlikely to present at a GP, then having community pharmacies there is really crucial. I will take that question out the front, and maybe I'll bring in everyone on that question, or maybe I'll just bring in a couple of people.
Hi, I'm Helen from the APPG, and actually Steve, you kind of cued my question in quite nicely there, which was more focused around vaccine confidence and uptake and perspectives of adolescents and young adults. So I think a lot of people have probably seen the long piece on the BBC this morning, which was communicating some of the data around particular drops in vaccine confidence among young adults, who obviously are kind of next lot of parents coming through. And the potential consequences of that, but also reflecting on a conversation that I had yesterday with a friend who has a daughter in year 9. 3 out of her class of 30 took up the flu vaccination, and they're now currently being offered HPV, and the conversation among the girls in the class is HPV vaccine makes you infertile. So even if you have parents consenting, you have kids repeating misinformation and potentially frightening each other out of having a vaccine, and all they have to go on is a great leaflet, but I don't think anybody is picking that up and having those kinds of conversations. So by the time the team come in, they don't have consent for the kids. So I'd be really interested to kind of get the views from the panel about how we handle that kind of situation in this kind of world of social media driven misinformation.
Yeah, so a question about misinformation.
So one of our other passions in Camden is adolescent health and wellbeing. So our annual public health report was on adolescent health and wellbeing, and we managed to persuade the council. We've got a TikTok account where young people are talking about health and wellbeing. We did a lot of engagement with young people. There's a lot of information. We're seeing this in declining uptake of the contraceptive pill and long reversing acting contraception, and it's feeding into vaccine misinformation around being natural. There's a sort of a thought process that you do not want to have any sort of interventions, which is causing significant health issues. We do need to engage with young people. I do think primary care need to engage with young people and adolescents in a much different way. So one of the key findings was that actually young people find it very difficult to make primary care appointments because you have to phone up during school hours. So actually one thing they do want is app-based appointments, which work really well, and most surgeries are now offering. But also pharmacy came up as well. So young people do find pharmacies acceptable and have word of mouth around which pharmacists are young people friendly. Many years ago we had the You're Welcome audit, which we did across primary care, which was sort of a mark of adolescent friendliness in terms of services. I do think there's something worth about bringing that back, because we are seeing young people getting information from social media, and we're now seeing the impacts of that in declining uptake of contraceptives which meets their needs, but also now immunisations. And what will be the future impacts on things like screening as well? We're not quite sure yet, but we are seeing emerging trends.
Yeah, I think again picks up on that point of convenience and how we can better use the NHS and other digital services. What I'm going to do is open up to questions, but I'm going to ask that you keep your questions very brief so we can fit in lots of people. We've got about 15 minutes left. I will try and fit as many people in as possible. We have a gentleman in the third row and another gentleman in the third row with questions, and I might take your question at the front as well.
Thanks. Simon Eccles, formerly NHS and now with Salesforce. Thank you, it's been a brilliant conversation, keeping it as tight as it can from COVID. Delivery is local, and trust is local, and initiatives are local, and all the cooperation is local. As we commendably move to April 26 and commissioning being local, are you going to give up the rigid hand of control on things like the IT that joins it all together? I'm absolutely in favour of the app, I think that's wonderful. But what we're seeing is people going, we're not allowed to do this, the centre says no, and so it's being a real challenge joining education, local government and health together. and local initiatives, in the nicest way, may work better than national.
Perfect, great question. Andrea, I'm going to bring you in.
Andrea Corazza, I'm responsible for policy and government affairs in Europe at Novavax. Thank you, Reform, and for your great report and event today, and thanks all panelists. For those of you that don't know, Novavax is a biotech company purely devoted to developing vaccines against infectious disease. We put all our efforts on COVID during the pandemic, and we developed and brought to the market the first protein-based vaccine. Now we're focusing on additional areas, flu, combination flu and COVID, that hopefully will help the convenience and increase the rate. And my question is on COVID. If Caroline can share any data from the campaign, the recent autumn campaign combining flu and COVID. In continental Europe, unfortunately, we see a continuous decrease in coverage rates and a huge gap forming between flu coverage and COVID coverage. So COVID coverage being much lower than flu one. Thank you.
Thank you. And the lady at the front.
Yeah, hi. My name's Tracy Chandler from the London School of Hygiene, where we have a health protection research unit in vaccines and immunisation, and we work closely with UKHSA as well. I have just one remark before I go to my main question around the adolescents. Well, I think it's really important to remember the role of schools or the lack of role when they're not giving access to community services coming in, so independent schools or religious schools. I know that's an issue with some religious communities. But I think there is a responsibility, requirement for education for kids to be, or young people to learn about vaccines in school. I worked with colleagues in Bristol and we developed a programme for HPV
Sorry,
vaccination.
can I ask you a question? So just so we can get through as many as possible.
Yeah, but I think we missed out the school bit.
Okay, yes,
it's
so
really important.
let's definitely do that.
And I'm just not plugging, it's just that we really think about the role of schools as another bit. But the other thing for me, it's really critical, and I know we all think back, COVID, wonderful, we had all this money, we did all these interventions, and they were great, but we didn't have a lot of evaluation data, and I'm really excited that you have got more. But I think we have to be careful, because evaluation data has to be planned really carefully, and it has to be evaluated rigorously, but there also needs to be the capacity at a local level to do evaluations as well of projects happening at local level. So just only not funding that is going to be an oversight, because we're going to have limited money and you're going to have to decide which one works and which one doesn't.
Perfect, thank you. Chris, I might come to you first on the rigid hand of control question.
I know, it's a bit of a cheek for Simon Eccles, who basically was, I would point out, the rigid hand of central control.
He's had a Damascene.
Yes, he's had a Damascene conversion, right. So look, Simon, you kind of remember, there's a really interesting dilemma here, isn't there? I mean, it's just completely pointless trying to have a whole bunch of local organisations building an NHS app. So we know there's absolutely bits of the IT infrastructure that it makes kind of complete sense to do. Equally, the lessons for NPFIT, from NPFIT, National Programme for IT, are absolutely crystal clear. Trying to have a single, electronic patient record system that you kind of run from the centre, again, doesn't kind of make sense. And you're absolutely right to identify there does need to be a degree of kind of local autonomy. I think, again, you were part of this. The way that, in effect, you kind of get the appropriate level of provision is, on the one hand, being really clear about where national does need to be national and keeping it tightly restricted to that, but then ensuring that you've got real clear common standards that anything that is developed at a local level needs to comply with, and then ensuring interoperability, so that effectively, if you've got 5 or 6 EPRs, let's say secondary care EPRs, and you've got let's say 2 or 3 primary care EPRs, it's absolutely vital all of those should be able to kind of talk to each other. And again, you'll know that we've put a lot of work over the last kind of couple of years to really be clear about what that infrastructure, what I might describe as a tech infrastructure strategy, should look like, and effectively where we kind of need to be clear about the kind of standards and the interoperability. And yes, I think one of the interesting things that is happening at a very strategic level, let's go up 2 levels, is it's really clear that with the creation of ICBs as statutory entities, we are absolutely crystal clear that they were created in order to provide a greater degree of local leadership that genuinely kind of takes account of local needs. I remember when I first joined, I sat at the knee of the NHS chief executive at that point who basically said to me, the thing you need to understand is we've very deliberately created a cookie cutter NHS where it's absolutely the same whether you're in Darlington, Durham or Derby. And the reality actually, and to be fair, there is a logic, that's why clue is in the word National Health Service. However, I think there's a real recognition that if we're going to really meet local health needs, ICBs, particularly because they involve an effective partnership with the voluntary and community sector, with local government, we need to really make that vision real, and that means we do need to devolve more, we need to decentralise more, but just recognise there are certain things that it makes sense to do national once, but just make sure it's the things that you absolutely have to do, not a whole bunch of other things as well.
Steve, did you want to come in on that point as well?
Yeah, if you wouldn't mind, I think I'm working for a company that sort of commissioned into the NHS. I think on the one hand you do have a national sort of structure in certain areas, but on the other hand where there are local commissioning decisions, often you get very, very good partnerships working, but that's never or very hard to roll that across the rest of the NHS. So we do have a very fragmented NHS as well. And I think that it's not my line, but taking the best of the NHS to the rest of the NHS is where we need to be. And there needs to be some oversight over that because it doesn't seem to happen naturally within the NHS at a local level. And I just say on ICBs generally, I think there needs to be some more democratic oversight of them because they are not very responsive, I would say. Certainly my experience as an MP is that they're not particularly responsive to local needs, actually, and they make decisions or certainly mine makes decisions with outcomes that are not easily explained and certainly not explained to local people. I think it's quite difficult to get in, and particularly for primary care, given that the entire primary care sort of sector has one seat on an ICB, and that's inevitably taken up by a GP representative. So there's more to be done on the responsiveness, I think.
Yeah. I guess it's a big question there, Steve, of local government's involvement in ICBs and being a genuine partner with the NHS. Caroline, there's a question on COVID data and particularly the kind of autumn round of uptake.
Indeed, I'll be quick. There is data published today, so I will let you have a look on that. But we've done just 9.76 million COVID vaccinations so far since the beginning of October. In terms of flu, we've done 18.1 million, but obviously different cohorts. In terms of flu, that is more flu vaccinations that we had given at this point last year, even though we started later, which is really positive. But I would just, because I'm very proud of RSV, I like to plug that we've done 1.375 million RSV vaccinations as well across older adults and pregnant women. I would just say, I think as the data is quite obvious, the older population are very compliant in terms of coming forward to their vaccination. There's definitely still more we need to do in different ethnic groups because there's still a level of variation there that I don't think any of us are happy with. I think there's more we need to do, but also the at-risk groups. So I think there are a number of people who don't necessarily either see themselves as at risk and therefore needing a vaccination, or it's just not a priority in terms of their life. So I think that's definitely one for us in terms of as we work forward for the future seasons, is really those groups that don't naturally prioritise either a COVID or a flu vaccination.
And Kirsten, can I just ask you the question on evaluation and how we make sure that evaluations are rigorous enough that we're scaling up the right things?
Well, lots of public health teams have academic partnerships and they do a lot of evaluation. Public health loves to measure stuff. That's what we do. We like data. So, but again, it's around resource and time. And also, I think local government, possibly they look at evaluation in different ways. So it's bridging some of that, I think, sort of language barriers about how we talk about sort of test and learn and innovation and evaluation. But I definitely think that it's happening. With the work that we have a large health intelligence team, academic partnerships, and I think probably that's one of our areas of weakness. I think other areas do it better than us. That's really one of our priorities. So I think it's something that happens, and public health welcomes academic collaboration, and the NIHR structure has made that more possible with significant amounts of additional funding. So I do think we have to, that is a win.
That's brilliant. I'm going to do a quick fire round, maybe just 2 more questions, and I stress quick fire, and then we'll come to the panel for closing remarks. A question from the lady at the front, and we have a second question right at the back. So I'll come to you at the front first, and then.
So hi, I'm Julie Mulloughlin, so I'm the National ADPH lead on immunisation. So we've obviously got quite a number of DPHs in the house today. So we do, one point is, DPHs do have an assurance role, therefore I don't think it's properly endorsed, and I think Caroline are having conversations about how it works with delegation as it comes down. But having heard everything what everybody said, you know, vaccines is a real innovative area. So there's huge numbers coming through. You know, we've got Baxter Zero coming in for gonorrhea and things like that. So how are we going to future-proof the system? You know, once it gets to ICB, that's one great, but there's a whole new story there. So for me, we need to do more than just say we're going to address access and, you know, inequalities here. It's how these huge numbers will be coming through. So how are we going to get jabs in people's arms really in an effective way?
A question on future-proofing the system, and one really, really quick question at the back, and then I'll come to the panel.
I was just going to kind of re-ask the question about schools and the role of schools in educating.
Perfect, thank you, Arif. Again, when it comes to the panel, and also an opportunity for closing remarks. So we've got one question there on the role of schools, and this question at the front as well. I don't know who would like to take.
I just think schools are hugely important with the school nursing workforce.
Yes.
Also recognising that not all young people are in schools, so it can't just be schools, it has to be youth and voluntary sector as well.
And the question on future-proofing. How do we future-proof the system when new vaccines come through? I feel like that's perhaps one for Chris and Caroline, but maybe one for Steve.
What I'd like to say is we do what we've set out in the strategy, and I think that's where, you know, we're putting these enablers in place so that we can respond quickly. It's an exciting time. There are lots of new vaccines coming through, so we've got to work on that model. We have a well-established model, but there's more we can build on. So I think that's the key thing, and that partnership working. So actually think about inequalities from the start. We don't run a programme for a year and think, oh no, there's a variation that we're not happy with. So I think it's really having that mindset. You know, we said we do what we set out in the strategy is my short answer.
2 minutes left, so I'm going to give a right reply to Steve and Chris if there's anything you feel that we haven't covered.
Great, thank you. I just think the final point is the really important role that we have to play in building and retaining trust in vaccines and in the health system generally, because if we don't do that, we will never meet the agenda of sort of preventing rather than treating, because people are simply not buying into the prevention sort of agenda. So we do really need to work on that building and retaining trust angle. And I think, you know, community pharmacy has a big role to play within the primary care sector, within the NHS sector generally.
Brilliant, thank you. And Chris?
Yeah, so let me just sort of end where I began, which is just to really reinforce the point of it's pretty clear to me that this whole agenda is going to become significantly more important, and you just need to look at, for example, you know, the importance that we've attached to RSV, but if you then look, you know, big news over the last, year and a half, the obesity drugs, you know, there's a whole 21st century medicine is going to really shine a much brighter spotlight on vaccination, where I think it's going to be really important for us. And in that, if that's going to happen, flexibility feels really important. The ability to rapidly introduce really effectively delivery of vaccinations, taking full account of health inequalities. Trust, I think, is a really important issue, and is one obviously we are thinking really carefully about at the moment. There is one more thing I wanted to say. I wanted to find an opportunity to say this, and I haven't had it, so I will now do it, not just because Steve is on the panel. I just wanted to reassure any of you who are in the audience from the community pharmacy sector that we absolutely kind of recognise that community pharmacy is a really key part of the NHS delivery network. We also wanted to very clearly recognise that that sector is under a huge amount of pressure, and certainly again I can reassure you from the seat that I have around our executive table and our private board table that actually we are thinking really carefully with colleagues in government about exactly what is it that we need to do to ensure that we preserve the importance of that element of our delivery network, recognising that it is under particular pressure at this point.
Perfect. And I think if there are 3 takeaways, then flexibility, trust, and community pharmacy are 3 of the best. That's a perfect note to end on. We have tea and coffee at the back of the room and an opportunity for networking, and we will share our report with you after this session. Thank you so much, everyone, for coming and giving up your time. And thank you to our brilliant panellists. I'll give them a round of applause.